All right. Hello, everybody. I'm Sharon Weston, and I'm going to be starting off our webinar tonight for SSCD, highlights from the Columbia Conference and DDW 2025. And I'll go ahead and share my screen. Okay. And so our agenda for this evening's presentation will include giving highlights from the Columbia Conference, as well as Digestive Disease Week 2025 that just happened last month. And we will have time for Q&A and then have our conclusion. And so our speakers for today's webinar include myself. I'm Sharon Weston, Senior Clinical Nutrition Specialist at Boston Children's Hospital. And then we have Dr. Amelie Therian, who is a GI clinician scientist at the Celiac Center at Beth Israel Deaconess Medical Center, working on several clinical and translational studies in celiac disease. We also have Dr. Telly Chung, who is a pediatric GI fellow in his third year at the University of California at San Francisco, and he will be staying on to take a faculty role at UCSF. And then we have Dr. Andrew Ford, who is a rising third-year adult GI fellow at Case Western Reserve University Metro Health, and he will be joining the Celiac Center at CCF as an attending. All right. And so I'm going to start it off by going over some abstracts that were presented at DDW, and I'm going to be starting off with this first abstract that was done by Andrew Kruger and his team from Cincinnati Children's, which evaluated the overlap of organic GI disorders and DGBIs in children. And so just to give some background information, DGBIs are increasing in prevalence and thought to be widely underdiagnosed. There are currently 17 pediatric DGBIs based on Rome 4 criteria. And research has shown that 25% of children in the United States meet DGBI criteria. There's significant cost related to testing and doing procedures for children complaining of abdominal pain with minimal yield and final diagnosis. And so the methods from this abstract included first a lit review of both pediatric and adult studies. Results showed that there was a significant prevalence of DGBI in pediatric and adult IBD, EOE, and celiac disease, which had psychosocial impacts such as lower quality of life. And the results found that children and adults with celiac disease who were adhering to a gluten-free diet and had declining TTG IgA levels presented with DGBIs. 43% of the cohort met DGBI criteria, including functional constipation, functional abdominal pain, nausea, IBS, and dyspepsia or gastroparesis. And in conclusion, there is a significant overlap between pediatric DGBI and organic GI conditions. A multidisciplinary approach may help these patients, and clinicians should consider screening for DGBIs in patients with organic GI conditions. Okay, the next abstract that I'm presenting was done out of Mainz, Germany. Aline Pessi and her team presented her poster on changes in cholesterol synthesis and cardiac inflammation during celiac disease in the mouse model. And so just as an introduction, active celiac disease is associated with a higher risk for cardiovascular comorbidities and shares inflammatory features. And so their aim was to assess how active celiac disease inflammation induces alterations in cardiovascular health. And they checked for key markers like cholesterol levels, vascular relaxation, and blood pressure in both female and male mice. So mice were sensitized to gliadin, and they were fed a gluten-containing or gluten-free diet for 2 weeks. And then cholesterol levels and other metabolites were measured to determine vascular relaxation capability. And so the results showed that mice of both sexes, first off, developed active celiac disease after exposure to gliadin. Vascular dysfunction was tested and shown to be impaired in the male mice when active celiac disease was triggered by gliadin exposure. Female mice undergoing the same treatment did not exhibit vascular dysfunction. Total cholesterol levels were also tested in both male and female control and gluten-treated mice. And figure 4 in the middle here indicates that the male mice with celiac disease showed a significant and stronger upregulation of cholesterol-related metabolites. Inflammatory markers in the perivascular adipose tissue were also measured, and that showed that, again, the male mice displayed increased alterations in the cholesterol-related pathways. And so they concluded that inflammation that is derived from celiac disease has widespread implications for cardiovascular health, and features may include increased cholesterol synthesis, decreased aortic muscular endothelial relaxation with elevation in blood pressure, especially in the males. And the results really warrant clinical perspective and possibly intervention studies in patients with active celiac disease. All right, the next abstract that I'm presenting had to do with understanding youth preferences for a mentorship program for celiac disease, a qualitative case study. And this was done by Ashley Dunn and Hillary Jericho and their team out of Stanford. And so first off, research shows that young people with celiac disease on a gluten-free diet often suffer from decreased quality of life and increased rates of depression and anxiety, and mentorship programs have proven beneficial for youth with chronic illnesses, improving quality of life, self-efficacy, and resilience, but there is limited research on the necessity and effectiveness of such programs for youth with celiac disease. And so their aim was to really understand the needs and preferences of adolescents and young adults living with celiac disease. And the goal was really to design a tailored peer mentorship program. Their methods included an N of 15 with an age range of 13 to 22 years of age, and the mean age of diagnosis of celiac disease was 7 3/4 years. And youth were recruited to participate in one of 3 online focus groups. And what they found was that there were 3 themes. The themes had sub-themes as well. And so theme 1 had to do with program structure and format. And the sub-themes really included monthly meetings over 4 to 6 months, scheduling flexibility to accommodate school and also after-school activities, and then having optional in-person and online activities on topics that centered around living with celiac disease. The second theme had to do with ideal mentorship relationships, and the sub-themes of that were really looking at peer-to-peer relationships matched by age, gender, and also interests versus mentor-mentee relationships. And then the third theme had to do with program concerns, and the sub-themes included safety and also respect and trust in a peer-to-peer mentorship relationship. And so the conclusions found that, well, actually the study findings were used from this to create the gluten-free Buddies mentorship program for youth with celiac disease. And participants were matched with peers of similar age. Age ranged from 13 to 25 years of age, and participants were encouraged to communicate at least once a month. There were safety checks done with the study team members to ensure ongoing success and adaptability. And future directions for this really included evaluating the feasibility and acceptability of this program among youth with celiac disease, post-program completion, also assessing the preliminary efficacy of the program on psychosocial functioning and quality of life, looking at 3, 6, and 8-month surveys compared to baseline, and then also exploring avenues to enhance peer mentor relationships and engagement with the program, look at the impact that the program would have on participants' dietary adherence and even disease management, and really investigate the scalability and sustainability of the mentorship program to reach a broader population of individuals with celiac disease. The next abstract that I'm going to present was done by Donica Matthew and also Ritu Verma and their team out of Chicago. And this was titled, "In the Shadow of Care, a closer look at impact on siblings of children living with celiac disease." And so just as an introduction, not much research has looked at family dynamics of celiac disease, particularly for the siblings that don't have celiac disease. And so this study evaluated self-reported psychological effects on non-celiac disease siblings of patients with celiac disease, particularly related to annoyance with making lifestyle changes and receiving less attention from their parents. And so the methods included a cross-sectional survey that first was developed and piloted to 8 non-celiac siblings of celiac disease patients, and then the survey was electronically sent out to all those who were established in the University of Chicago Celiac Disease Center. Patients were diagnosed with celiac disease at under 18 years of age. And questions included looking at things like feelings of less attention, annoyance around the sibling with the celiac disease diagnosis, anxiety around the sibling's diagnosis, disordered eating patterns of the non-celiac sibling, and episodes of disruptive behavior related to the diagnosis. The results included 174 participants. The majority, 56% of the sibling respondents were 10 to 14 years age range, and more than half, 58% of non-celiac siblings felt that they received less attention from their parents compared to their sibling with celiac disease. 69% of the non-celiac siblings felt annoyance with changes in their daily lives, such as maintaining a safe home, limiting choices in restaurants, creating new family traditions around food. And finally, they found that 100% of the age cohort did not feel guilty for not having celiac disease. And so the results of this study really highlight that non-celiac siblings of patients with celiac disease often have psychosocial effects related to making changes in the home and feeling that like they receive less attention. And so this really addressed the needs of those siblings in managing chronic illnesses, and they recommended extending resources for the entire family and addressing the emotional aspects alongside clinical care needs for the patient. And future investigation will focus on these mental health concerns and family dynamics to develop support systems and create interventions for healthy siblings. Okay, the next abstract I'm going to present was done out of the University of Alabama at Birmingham by Soha Abbas and their team. And this was assessing the quality of YouTube videos on celiac disease delivered by experts versus non-experts. And so just as an introduction, more than 40% of adults report using YouTube to watch videos related to health. And so the objective of this study was to compare the quality of celiac disease related health information delivered by experts versus non-experts. And so methods included doing a YouTube search for celiac disease, looking at 10 expert and 10 non-expert videos. The expert videos were identified by accreditation information that was on the video. And then 3 independent reviewers assessed each video using the PMAT tool to determine the quality, such as understandability and actionability of the videos. And then they did a statistical analysis. And the results showed that expert videos were shorter, they had a higher number of views, and scored higher presenting information in a logical sequence, summarizing information, and displaying easy-to-read text, and using clear illustrations and photographs, whereas the non-expert videos performed higher for overall understandability and actionability components. And so in conclusion, given the frequent use of YouTube as a source of health information, there's an opportunity to create expert patient education videos with higher understandability and actionability. And finally, the last abstract that I'm going to present was done by Ann Lee and her team out of Columbia. They presented a very interesting study related to quality of life of patients with celiac disease and assessed gluten transfer via kissing. And so their objectives were, first off, current management of celiac disease depends solely on a restrictive gluten-free diet. Maintaining a gluten-free diet requires diligence, which can impair the quality of life of these patients. And studies have reported celiac disease patients' anxiety about gluten transfer via kissing, but data to support this concern is lacking. And so the way that they did the study was they tested the potential transfer of gluten through kissing by measuring the amount of gluten in saliva in this cross-sectional study of 10 couples. One partner had celiac disease and one partner did not. and the non-celiac disease partner consumed a gluten load, which included 10 saltine crackers, which provided an equivalent of 590 milligrams of gluten. And they picked the saltine crackers because it was convenient and easy to provide these consistently to all of the subjects. And also, they're very sticky in the mouth. So when they ate the saltine crackers, there was a lot of gluten that was really sticking inside of their mouth. So then they had two protocols. And so for the first protocol, for both protocols, the non-celiac disease partner consumed the gluten load and then kissed the partner with celiac disease. The kiss had to be open mouth for at least 1 minute, involving the tongue and saliva transfer. And for the first kissing protocol, the non-celiac disease partner waited 5 minutes after eating the saltine crackers before kissing the partner with celiac disease. The second kissing protocol, the non-celiac disease partner ate the saltine crackers, then drank 4 ounces of water, and then immediately kissed the partner with celiac disease. Saliva was collected from the partner with celiac disease immediately after the kiss. And then saliva samples were tested for gluten content by the R5 enzyme-like immunosorbent assay. Gluten detect urine, gluten immunogenic peptide tests for urine were provided to the celiac disease partner to measure urine levels the evening of the kiss and also the following morning. And then they also assessed the potential amount of gluten that was transferable by measuring the amount of gluten in the saliva of the non-celiac disease partner that ate the saltine crackers in 4 protocols, waiting 5 minutes, 15, and 30, and then after drinking the 4 ounces of water. So the results, first off, gluten was detectable in the saliva of both the partner with celiac disease and the non-celiac disease partner. The amount of gluten ranged from less than 5 parts per million to 153.9 parts per million in the partner with celiac disease. And you can see in this table here, the first column was protocol 1, where there was no water consumed between eating the crackers and kissing. The second column was protocol 2, where there was water. And so what they found was by drinking 4 ounces of water, this decreased the amount of gluten in all of the celiac disease participants to less than 20 parts per million. In the protocol 1, there were only 2 celiac disease participants that showed greater than 20 parts per million. No symptoms were reported post-kiss in any partner with celiac disease. Also, the GIP urine tests in the evening, there was only 1 positive GIP urine test in the evening in the participant that had the high level, that 153.9 parts per million in the saliva. And the non-celiac disease partners, the amount of gluten ranged from 19 to over 2,500 parts per million. And so in conclusion, they found that gluten is detectable in the saliva after ingestion, but there's not an increased risk of significant cross-contact when kissing a partner who consumed gluten, especially if you drink 4 ounces of water. These results really are very interesting and really kind of can help us guide our clinical practice, and we should be sharing this with our patients. So the key takeaways here are, first, there's minimal risk of cross-contact with kissing. The risk can be reduced with 4 ounces of water being consumed, and we need to adapt our counseling for individuals with celiac disease. All right, and I'm going to now pass this on to Dr. Amletherian.
All right, I'm sorry about this. It won't take long. And then I do this. Okay, share. All right. So yes, so I'm going to talk about the Columbia International Symposium that was just before DDW. I will present a broad overview of some of the topics that were presented, and Kelly will go more in details for some of the talks. See. Okay, yes. So Dr. Pinto Sanchez kicked off the symposium with an non-celiac gluten sensitivity and their review about how most of the well-designed randomized controlled trial, blinded, double-blind placebo in non-celiac gluten sensitivity were about gluten as a trigger, even though we are always hypothesizing that there are other proteins that may trigger the symptoms, such as ATI, high-glutenin, glyphosate, but there are no well-designed studies about this. I invite you to look at their review in American Journal of Gastro. So basically, so far, most of the well-designed studies are about like gluten and gluten sensitivity, and not the other component of wheat. She mentioned their prospective clinical trials with IBS patients who had self-declared wheat or gluten sensitivity, who were challenged with either gluten, wheat, or gluten-free nocebo, and reevaluate their symptoms and whether or not they could see what they got, like whether or not they had gluten or in fact the gluten-free nocebo. And the majority of the patient could not identify correctly what they had received. And congratulations to their team. That paper has been accepted at the Lancet. So another upcoming reads if you are interested. And finally, in her talk, she mentioned like this study that I was not aware of about like fecal calprotectin levels in patients with non-celiac gluten sensitivity. So in this study, they compared people with non-celiac gluten sensitivity and people with IBS functional dyspepsia, and they found that overall the calprotectin was higher 42 in the people with non-celiac gluten sensitivity. About like 2/3 of them had elevated calprotectin. And when it was positive before the gluten-free diet, it tended to decrease, normalize after going on a gluten-free diet. So this indicates that perhaps in some people with non-celiac gluten sensitivity, there could be some implication of neutrophils or macrophage activation, as we know that calprotectin is produced.
Looks like we might just have a minor connection issue. I'd be happy to add my parts, and I'm sure Emily will, once she joins back, she'll finish up with us. So why don't I share my slides just to give us our full hour?
Thanks, Tilly.
Yeah. Let's see if I do this correctly. Okay. That looks okay, guys. Okay. Great. Well, to continue on our discussion about the Columbia conference, I just want to say this is a fantastic talk. My background is a pediatric gastroenterologist, and to that regard, I was really excited to see representation among our pediatric gastroenterologists at the symposium. There was a lot of wonderful talks, and I'll highlight some that were of interest to me. As a trainee at the doorsteps of graduation, I thought that this is a fantastic symposium for me to learn a lot about celiac disease. And one of the ones that stood out to me was one by Dr. Ritu Verma, emphasizing the importance of the child-parent-physician dynamic in the treatment of celiac disease. And Dr. Verma gives us a fantastic way to frame this understanding of this dynamic. As a physician, I think of myself as that medical expert. Dr. Verma expands that framework to include the child and the parent as well, where the child is the active participant and the parent is not only just the advocate, but the enforcer and the emotional supporter. Dr. Verma goes on in her talk to give us a way to look at the many, many roles of this triad. If we focus all the way on the right, that's where I feel that my focus has been, where it's how do I educate myself in celiac disease? How do we optimize the multidisciplinary care we provide to our kids and households? How do we treat it with a dietary therapy? The focus of my research has looked at quality improvement ways to look at food insecurity screening, and that has been important in my work. As we look toward the child's perspective and the parent's perspective, Dr. Verma gives us a way to understand that in greater depth. Sharon had presented one of Dr. Verma's research projects looking at the sibling without celiac disease among a household with celiac disease. And I think understanding where that child's perspective is relative to their siblings, their teachers, their friends, their after school groups, their extracurricular activities, all those things are very important. And in addition to that, among the parents' perspective are other aspects. For instance, how does the extended family, cousins, uncles, aunts, etc., how about the parents' friends? We think about their teachers, their social network, and their advocacy group. All those are super important aspects of what Dr. Verma presented for us to understand in the dynamic. And these feel very straightforward, but I do think it's worth emphasizing some of the tips that Dr. Verma gives us, strategies for success that include involving the child early in the visit, avoiding the aspect of being judgmental, empowering parents with resources. For me, I think this resonates very strongly, but that shared decision-making among the child, parent, and our team, that is very, very important. And a consistency among messages among the care team. Those are very important aspects. In addition to support groups, this is, I think, potentially a primary thing that families get exposed to outside of just the medical care they get, who are the people that they talk to and the friends that they talk to. I think that is an important aspect of success in treating celiac disease. Beyond that, one additional talk that was a very interest for me was by Dr. Marissa Stahl. She presented work looking at the current gaps in celiac disease screening. And she frames for us 3 ways that we're not doing an adequate job of screening for celiac disease. Number one, of the professional organizations that we consider important in pediatrics and adult gastroenterology, none have given us a necessary cadence for screening celiac disease. They tell us which high-risk conditions to consider for screening, however, not necessarily how often to screen our general population. And caveat number 2, as we think about those recommendations and screening for those that are of higher risk, the question is, how well are we doing? And not as well as we think we do. Dr. Stahl presented studies that looked at maybe approximately 5% of patients with high-risk conditions are getting screened, and potentially 30 to 50% of patients with type 1 diabetes or family history were screened. So not by any means in that 80, 90, 100% range. And then thirdly, as we think about symptoms in defining how we screen our patients and where we're looking for cases to screen, even that aspect is not being implemented. The analogy that Dr. Stahl presents is that we believe that symptoms is a way to screen for celiac disease, but Dr. Fasano's work and his study showed that even among those that are asymptomatic, are not truly asymptomatic, and that leads to gaps in how we screen patients based on just symptoms. So relying on symptoms and high-risk associations for celiac disease screening is not effective. Dr. Stahl also presents a rhetorical question for us. Why should we consider general population screening for celiac disease? Among those that are green are things that were understood, and yellow are things that we're working on. We know that celiac disease is common and it's well defined. We understand its pathogenesis and ways to treat it with a dietary therapy. The screening test in terms of serology are blood tests that's feasible and acceptable. Screening is also culturally acceptable. And we think that clinical detection by just symptoms alone is also difficult. And these are reasons to do more screening for celiac disease. One additional note I'll add is looking at testing and treatment being effective is out of Dr. Stahl and Dr. Michelle Corrado's work, they showed that doing up to five TTG-IgAs is as cost effective as doing one HLA testing. So there's some other aspects to that allow us to promote screening for celiac disease. And Dr. Stahl also gives us a mental model to potentially do screening, where we understand in pediatrics, or at different parts of their pediatric general practitioner care, there's lead screening and there's lipid screening at an early age and a later post-pubertal age as part of their regular care. Looking for serology at those different time points is a potential way that we can envision celiac screening. I'll just briefly add work by Dr. Carlo Cattassi as well, where this is mass screening for celiac disease in Italy as an extension of his work through his D1C, his and their team's D1CE program, where they're doing mass screening in Italy. They propose an algorithm to do mass screening in Italy, where they are screening for HLA-DQ2 and DQ8 in the neonate. And among those that are positive, they go on to get more frequent serologic testing for tissue transglutaminases. They recommend TTG-IgA at 2 to 3 years, and if negative, repeating it at 5 years later. And among those that are symptomatic, that may be a trigger to screen sooner again. And among those that are negative for HLA-DQ2 and DQ8, that may not be a high-risk population that we screen for, unless there are other clinical reasons. I'll add, in addition to clinical work and screening work, this is another interest in the adult and pediatric world, and it's an ongoing question. Dr. Stephanie Molesky presents benefits of screening, benefits of diagnosing based on serology, and benefits of diagnosing based on biopsy. And these are, flipping a coin and seeing two sides of it. So benefits for one are disadvantages for the other. Starting on the left column for benefits of serologic diagnoses, we know that TTG-IgA has a good test performance for predicting villus atrophy. She presents work that's shown that the positive predictive value for TTG-IgA greater than 10 times upper normal limit has 96 to 100% positive predictive value for villus atrophy. And probably one of the more important parts of serologic testing is the cost effectiveness. Serology is more cost effective than biopsy diagnoses. With that said, we think about the technique and now the limitations of biopsies, where we know that pathology isn't perfect. There's a usability component to things, to reading, to processing, and staining the slides and the biopsies that we obtain. And out of, I believe, Dr. Lebowall's work, we know that multiple bites of the duodenum can lead to misorientations and just ways where we're not reading the histology as well as we could. So there are technological aspects that limit biopsy-based diagnoses and give a little bit favoring to serologic diagnoses. As we think about positives of biopsy-based diagnoses, I think the key is it does help reduce some of the false positives, those that don't truly have celiac disease. An aspect is that for serology for TTG-IgA, these values are not necessarily standardized. For instance, what does 3 times, 5 times, or 7 times upper normal limit mean diagnostically? We have definitions for 10 times upper normal limit, but that's not as well defined outside of that. And again, we're avoiding the misdiagnosis of other enteropathies that may exist. Now commenting on the cost, and this is more so the psychosocial burden of a gluten-free diet. Work by Dr. Joe Murray that was published, I believe, this year in gastroenterology, looked at the psychosocial burden of celiac disease, and having a biopsy diagnosis and confirming that would more favorably commit a patient to a gluten-free diet as opposed to having a false positive. And then lastly, I'll just add, there are practice variabilities among pediatricians in diagnosing celiac disease, and they may not always adhere to serologic guidelines. So this is where biopsy gives us a little bit more clarity, in addition to a way to monitor outcomes in clinical trials. So that That's an important aspect of biopsy-based diagnoses. I'll end with the last part, a research part of the Columbia talks. And All of Us is a longitudinal cohort study that's based in the US with a relatively large data bank. I thought this is relatively analogous to the NHANES that we have seen and used in the United States. This is, I believe, a voluntary-based network that takes into account electronic health records, surveys, and the important aspect of this work that Dr. Kong had presented is the genomics. There was genomic data in this that was relatively robust. But I do think in thinking about the limitations of voluntary work, there could be a selection bias where we're screening the people that want to be screened, and it's missing the people that haven't or can't be screened. So I think that's important as a perspective to this work. I'll just present, I believe, 2 slides on interesting work that Dr. Kong had presented. Different ancestries with celiac disease have varying HLA-DQ, HLA-DQ genotypes. If we look at just, I think, grossly the different colors, if we're looking among those that have European and mixed American or African descent, we see that those that have celiac disease have different profiles of their DQ 2.5 or 2.28 and beyond genotypes. And I think that's a very interesting part of this genomic survey of this data. And lastly, I'll add, and this is a lot of data, but I think I'll just focus on the fact that on the right side, if we look at the vertical column among HLA-DQ risk, Dr. Kong had divided these among high, moderate, low, and no risk. Things of interest for me is that if we look at the TTG-IgA box, those that are of higher risk have higher levels compared to those that have lower, moderate, low, or no risk. And that seems to continue among our deaminated gliadin peptides that are used for screening. So the conclusion here is that different HLA-DQ genotypes have varying levels of celiac serology. I think that's important. The takeaway from this is using a large database type study nationally is an important way that we look at generalizable research to not just at one center, but throughout the US. So I think this is important work that should be extended. And I'll pause there.
All right, let me just pull mine up. Okay, just 1 more minute. All right, so those are some excellent topics, and somewhat related is the study that I'll be sharing. So I'm Andrew Ford. I'm a current gastroenterology fellow at Case Western, and I'm excited to share some work that the team at Cleveland Clinic and we did to look at specifically celiac disease testing, and we looked at disparities in celiac disease testing and found that there's a high area deprivation index association with lower frequency of testing, and I'll get to the specifics of that in a second. So, as we all know, the duodenal villus atrophy is a very key feature of celiac disease, and sometimes when we do endoscopies for reasons not even necessarily suspecting celiac disease, we can find it happenstance, and it can be a peculiar situation. But one of the things that should be done, obviously, is because of that association, there should be serologic testing. Unfortunately, that testing doesn't get done as often as it should. When we saw this, looking at some retrospective data, we wanted to figure out why that was. So we wanted to look at factors that were contributing to the lack of celiac disease testing in patients with newly found villus atrophy. So we did this as a retrospective cohort study, and included all adults that were above 18 years old, and they obviously had to have biopsy-proven villus atrophy. We excluded those who had serologic testing prior to biopsy. and also those with unavailable demographic data, because we did want to see if there were contributions from their demographics. The primary outcome obviously was serologic testing, which we defined as IgG or IgA tissue transglutaminase, endomysial antibody, or deamidated peptide. And the variables that we looked at included many socioeconomic factors such as age, sex, race, ethnicity, state area deprivation index, which is a very nifty tool that looks at socioeconomic deprivation, and it kind of ranks it as decile. So the higher the deprivation index, the more disparity there is in that area. And then we just created a model with multivariate logistic regression, and found the odds ratios for each of those variables. So ultimately, we found, looking back at 10 years, that there were 2,939 patients with villus atrophy and without serologies checked. Of those patients, 1732 had serologies checked. 1207 were not checked. So then, plugging into the multivariate model, that showed that only the high decile for area deprivation index, you see the odds ratio there is 0.55, and then younger age, odds ratio of 0.99, so almost 1 and not terribly effective there. Those were the significant associations. Race, sex, ethnicity, they had no effect whatsoever. It's interesting to note that the univariate analysis did show somewhat of an effective race, but that was wiped out by the addition of area deprivation into the model. So this just goes to show some of the demographic features of our groups. You see overwhelmingly Caucasian, as is typically the case in celiac disease, but still a pretty large number of African Americans, relatively speaking. Asian Americans, smaller number, and then multiracial. Unfortunately, didn't clarify which were the multi races, so that is just worth noting. And then this just goes to show the specific odds ratios and p-values that we got out of our multivariate model. Obviously, the most profound effect coming from the area deprivation index. So what all of this can be taken to mean is that it seems that the socioeconomic status has some relation to whether or not people are getting tested, and that's somewhat intuitive, but it also just underscores the fact that there are very likely disparities that are keeping the people who need to get this testing done from getting it done, and it's inherent on us to find ways to bridge that gap and make it so that they can get this testing and identify the patients that need this. So with that, I will turn it over to Dr. Therian, and thank you all.
Yes, hi, sorry. I hope my internet connection will now be okay. So hopefully, and I was told that I dropped at the time of the calprotectin. So let's return into that. Alrighty, so I was saying that I was not aware of that last study about calprotectin and non-celiac gluten sensitivity, where they compared people that had self-declared non-celiac gluten sensitivity and people with IBS, functional dyspepsia, and they saw that people with IBS all had a calprotectin lower than 42, while 2/3 of the people with non-celiac wheat sensitivity had a calprotectin over the threshold of 42, and it decreased going on a gluten-free diet. So it indicates that in some people with wheat or gluten sensitivity, there could be some implication of neutrophils or activated macrophages, which are the main producers of calprotectin. We had a long session about update on drug development. I just want to point out 5 drugs that are currently being trialed in the world. So we have TAC101, that is a nanoparticle, heterogenic molecules that is currently trialed in well-controlled celiac disease in several countries with a component of a gluten challenge. TAC227 is a TTG inhibitor that is orally currently trialed in Europe for non-responsive celiac disease. This is a real-life study. Amlitelimab is an anti-OX40 ligand that is given subcutaneously, that is also being trialed currently in the United States in non-responsive celiac disease. These are all like phase 2A, phase 2B that are currently ongoing. DONG52 is an HLA blocker currently in phase 1C, meaning that they are including some patients with celiac disease that they are trialing with a gluten challenge. And finally, TEV-54403 is an anti-IL-15 undergoing a proof of concept study with well-controlled celiac disease, also undergoing a gluten challenge. So still no drugs going into phase 3, but there are different like mechanism of actions that are being trialed right now. And also in the topic of clinical trial design, Dr. Leffler presented some clinical trial methods. So the CDSD is a questionnaire that has now been validated in several clinical trials. We had an old version until like 2020, and since 2020, 2021, we have been seeing like this newer version in our clinical trials. I think it's simpler compared to the prior version where the participants were confused about the constipation questions, and there is a severity and frequency component. There has been also several data presented by him and then by Dr. Chupan about the benefit of giving SIEGE bar. SIEGE means simulated inadvertent gluten exposure during clinical trials. So it's a small like bar that contains 500 milligrams of gluten, and it's given to the participant like 3 times a week. And this way, we are sure that the placebo group does not spontaneously improve because they are more adherent to their gluten-free diet being in a clinical trial, which has been one of the pitfalls of several like past trials in celiac disease. So this way, the placebo groups get a little bit of gluten exposure throughout the trial, and we can compare this with the group that actually has the drug. Dr. Lebwohl presented about indication to do a follow-up biopsy, and he mentioned this recent review that he and Dr. Ludvigsen co-wrote about complications and comorbidity of celiac disease. It's published in Nature Review. I encourage you also to look it out. It's very great. And this figure, I think, is very helpful, summarizing the diverse like population studies and odds ratio, hazard ratios about the risk of complications when a patient has persisting villus atrophy. So it can help also our discussions about like people who are asymptomatic and are unsure about like being strict on their gluten-free diet, or why are we repeating biopsies and why are we like insisting to be strict on the gluten-free diet, etc. So this was a great summary coming out of that paper. And finally, there were a few talks about refractory celiac disease. We know since last year that tofacitinib could be an option for these patients. Tofacitinib is a JAK inhibitor. Dr. Celiac mentioned that they are also trialing it in France. And their new management algorithm is to try open capsule budesonide first, and then tofacitinib if there is a failure with open capsule budesonide, and then an autologous stem cell transplant. Tofacitinib is not a perfect treatment. In the Netherlands, Germany, their cohort had 2 patients treated with tofa who have developed an EDOL so far. And for those involved in the diagnosis of refractory celiac disease, Dr. Bagad, the pathologist from New York, reminded us that sometimes you may have cells that are CD3 and CD8 negative, but they are in fact innate lymphoid cells. So it's important to stick with the initial criteria of having like more than 20% aberrant T cells on the flow cytometry, or more than 50% aberrant T cell on the immunohistochemistry, and to do intracytoplasmic CD3, to look at the other clinical parameters, to not overcall a diagnosis of refractory celiac disease just because on the immunophenotype there is like CD3 neg, CD4, CD8 negative. And also sometimes I personally have that experience, like some pathologists mentioned in the report how some cells are CD5 negative, and it seems like worrisome, something aberrant. but the CD5 expression varies on IEL. So that alone, when you see that on a report, is not necessarily a cause of concerns. So these were my main pearls about like the symposium, just a broad overview of things like to read or to watch for. I think we may have time for questions if Kelly, if we have.
Yeah, I mean, we we have a bit of time for questions. I'm happy to start us off as others think about the talks we just had. I'm curious, Sharon, as someone that has created videos for celiac disease, in the context of that abstract, I looked at quality of videos among that are created by experts not being as well understood. How are ways that you've navigated that aspect of creating those videos?
I think that's a great question for Vanessa because she's like our video expert. Yeah, I mean, I think that like when you look at some of the videos that are available on YouTube and also TikTok, the ones that are non-expert, I think that possibly they're just more reachable, you know, in terms of like just their coolness, or I don't know, you know. So I think that experts, we just need to look at those videos and see like what the flair is, and really, you know, be able to be maybe more like peer to peer, right? Is something that may be an aspect to think about. So including other people in our video, like, as you know, doing expert videos, including other people that may not be experts, may be a way to get around it.
Yeah, great thought, Sharon. And I wonder if there is some aspect to the production of videos that make it more interesting and helps with their understandability. Okay,
Yeah.
great.
Yeah.
I think making them really short. The longer the video, the less anyone is going to listen. And I guess depending on your audience, so maybe even figuring out what is your particular audience, what are the pain points, but short and sweet. The longer it is, the worse it gets. And no one that, you know, the attention span is 2 seconds. So have to have a powerful message impact in a minute.
Yes.
Great
Yeah.
thoughts.
Impact.
Great thoughts.
Yeah. Yeah.
And Anthony, Drew, one of the conclusions of your work is that it sounds like among groups that have higher deprivation, their likelihood of getting screened it sounds like about half as likely. Do you have inclinations as to why that might be the case?
Yeah, I mean, I think it's multifactorial. I think in part it's the availability to testing facilities, period. I mean, those areas generally have less direct access to healthcare, generally less transportation that they can take, especially public transportation, when they don't have means for themselves. But I think there also may be a component of awareness. Maybe they're in areas where the awareness of celiac disease is a little lower, or not expected, as much as it would be if you were close to, say, a celiac disease center. But obviously it's impractical to be putting centers in every single city. So there has to be a way to bridge this without, in a way that would be manageable. So I think it's part patient-centric, part we could be doing a better job as practitioners.
Any other questions that may have come up?
I guess from the practitioner standpoint, you know, there's more education and support. So what I've heard from some primary care, they don't want to order a celiac panel, because then they don't know what to do with it. Or there's no one to receive that positive serology or equivocal serology. What do I do with that? So I think availability, or having some tools that we would spread to primary care, what do you do with that? And maybe having a hotline for the gastroenterologist in terms of how do you connect with somebody and how do you make a diagnosis. I think that ends up to be sometimes like a big deal. where I don't know what to do with it. I'm not going to order it. And especially if someone doesn't have the typical sort of symptoms.
Right, especially in the scenario in this in this work where we are finding people who have villus atrophy, where celiac disease maybe not have been expected even, and somebody who's ordering the endoscopy for maybe iron deficiency anemia or maybe even something like just dyspepsia. They may well not have any idea of what to do with that finding of villus atrophy. And to us as gastroenterologists, it's very straightforward, order the serologies, but that may not be the case for primary providers. So definitely finding a way to bridge that gap between the GI specialists and primary providers may help avoid this issue.
I think just to comment on what we do at Vanderbilt, and we're trying to improve that specifically, but within an academic center, I wonder if it could be applied. So our pathology reads always suggest sending serologies if there's atrophy. And then we have a new service, an e-consult, which I found pretty helpful. I started it about 6 months ago, where if someone has a positive lab, they can just put in an e-consult, and I never have to see the patient. I can just say, I look at their labs really quickly, and we say, do a scope, see in clinic, get HLA. I don't know if something like that could be applied on a multi-center outside of the academic institution as well. But it's been helpful for our large medical center and primary care doctors so far.
I think that would be awesome. I mean, if it's something that we could just do, or even through the SSCD, have a e-consult or something that one could help out with that. Because as as we're looking at, I mean, how can we really have big centers everywhere? I mean, it wouldn't be even possible, but maybe not even necessary to have that. But having this sort of an e-consult service, but that sounds really great. Dawn, with that.
I agree that it's not possible to have centers everywhere. And I think our endocrinology colleagues are actually really good at this. And they have models for how to help with remote monitoring for type 1 diabetes. And so they have like Ask the Experts, for instance, which is funded by JDRF, Breakthrough T1D, where even like local endocrinologists who don't know what to do with test results can reach out through this program. So it kind of would be similar to what you guys are talking about.
These sound like all novel ways to improve that connection between a gastroenterologist and pediatricians, which I think we need. Just make sure we're okay with time. We have a minute or so. Any other questions we can answer?
So I have a question. Do the DGBIs improve when you go on a gluten-free diet, Sharon? Or do they worsen?
They actually, I think that what they found was that there was already declining TTG levels, and they were already on a gluten-free diet, and there was still a high percentage of DGBIs. Yeah, very hard to.
Yeah, there was another abstract at DDW showing like even more DGBI after going on a gluten-free diet. So seems to be independent.
And I guess if you're calling DGBI as constipation, I mean, I think that at least in the pediatric world, 90% have constipation. So whether it's because of the gluten-free diet or otherwise, but interesting, I think, just to think about it and probably put that in a multidiscipline clinic or something that you could really help the children and not just constantly blame their symptoms on you must have ingested gluten with that.
Yeah.
You guys have done an awesome job. This is great. Thank you.
Yes, so we just have one final slide to put. Sorry, it's not sharing well. I'm going to put it back normal. Stop share, and then back on. Tonight is not my night for the Zoom. Okay. So So yes, so we will take a little hiatus for the webinar with the summer. Please note that most webinars are recorded and posted on the SSCD website for members. We invite you to look at the website for more information about the SSCD. We have a very dynamic webinar committee with various interests, dietitian, GI, adult GI, PGI. So it's a very rich. Thank you for the SSCD consult. And we now have a QR code if you wish to access the website, the membership page. And there are several benefits to be member of the SSCD. There is up-to-date information about celiac disease, information about like new society statements, mentorship. We have a great mentor peer-to-peer program, some grants also that are being awarded for travel awards for conferences, research grants, and lots of opportunities to get involved in celiac disease. Thank you.
Great, thanks, Emily.